Hello, everyone. My name is Christine Karapetian. I am a board-certified periodontist. I did my training at NYU College of Dentistry, and I stayed on for 3 years to perform my postgraduate studies in periodontics and implant dentistry. So today's topic on working with your dental hygienist in the world of periodontics hits very close to me and is also very important to me. I am a practice owner in Northern Virginia, and I work very closely every day with my hygienist. So as you know, our title is Working Collaboratively with the Dental Hygienist in the Treatment Planning of a Periodontal Patient. If you have any questions throughout, please don't hesitate to let me know. I would hope that we can have a lively discussion. So some of the learning objects for tonight are first and foremost to determine how we classify or diagnose our periodontal patients. So we need to determine what the classification system is. We need to determine why they develop the disease or the etiology of the disease. We also need to do some data collection, such as the medical history of the patient and also the dental history of the patient. Then we can start talking about what the actual physical roles of each clinician or each practitioner is, whether it's the dental hygienist or the dentist. So let's continue on. First, we're going to talk about the classification system. So as you can see in front of you, there are 4 case types of how the ADA classifies periodontal disease. Now, this is not the diagnostic system that the American Academy of Periodontology uses. So this is simply developed by the ADA, and it was initially devised so that we could easily communicate with the insurance companies. So case type 1 is the gingivitis patient. And what gingivitis means is that the patient has inflammation of the gingiva. There is no attachment loss or bone loss. It just simply means that the patient has gingival inflammation. The type 2 case is called early periodontitis. The important part for this is that there is attachment loss. There is bone loss. And this is where some math comes into play, where we need to calculate the amount of attachment loss, and that'll help determine whether it falls into the early or the case type 3, which is the moderate, or the case type 4, the severe periodontitis. This is slightly different from what the American Academy of Periodontics uses. The American Academy of Periodontics, what the classification system that they use is more detailed than this one. But this is a good jumping or starting off point, and it's especially important for the insurance companies. So next we're going to talk about the etiology of periodontal disease. And etiology basically means why the disease occurs. Now we know that there's 2 types of bacteria in the oral cavity. You have the gram-positive bacteria and the bad gram-negative bacteria. The gram-positive bacteria, we would like to be at a higher level than the gram-negative, because those are the types of bacteria that keep the gram-negative at bay. So over time, the gram-negative bacteria start increasing in numbers, and unfortunately in patients who have periodontal disease, the gram-negative bacteria begin to cause destruction. They begin to mount an immune response, and unfortunately the immune response in periodontal patients goes haywire. What that means is the immune response actually begins to cause destruction of the periodontal tissues, the bone, the gingiva. So the primary etiology of periodontal disease is the bacterial plaque in a susceptible host. The secondary factors most of us may know about are things like calculus, plaque, smoking, diabetes, open contact, malpositioned teeth. There's many different secondary factors. And some of these secondary factors are factors that can be modified. Things like calculus, we can remove calculus. Smoking, a patient can quit smoking. Diabetes, unfortunately, is not a modifiable disease. Diabetes is something, whether it's type 1 or type 2, we can control it, but we can't ever eradicate that disease or cure that disease in a patient at this time. So though we can change our status, we can never get rid of the disease, if you will. And malpositioned teeth, always orthodontic treatment with open contacts. You can close contacts with restorations or with orthodontic treatment. So if there's no questions, we'll continue moving on. The way we determine what the etiology of the patient is by doing a comprehensive periodontal or a comprehensive dental examination. And we always start that with an intraoral exam or head and neck exam, feeling for any lymph nodes or muscles that may not be in a relaxed position. We check the on the temporomandibular joint. And then we also go into the oral cavity and check the hard and soft palate, the floor of the mouth, the buccal mucosa, and et cetera. And then we go on and check the teeth. I normally like to start by identifying which teeth are present and which teeth are missing, whether they haven't erupted yet or they have been extracted or the patient's lost the teeth for whatever reason. Once I've done that, I check for caries, because after all, we need to look for all types of disease. Just because I don't treat caries as a periodontist doesn't mean that I can ignore that disease that occurs in the patient's mouth. So I will look for caries, and I look for open margins, make sure the restorations are all proper. Once I've completed doing a tooth evaluation, then I go on to look at the periodontal health of the patient. Something as easy as just scanning the patient's mouth to look at their oral hygiene. How well are they able to control the plaque? How much calculus and plaque is present throughout the patient's mouth? Is there inflammation? Is the inflammation generalized? Is it localized? I also like to look at bleeding. So when I'm probing the patient, I always like to make a note of the bleeding. Is it generalized? Is it localized? Where does the bleeding occur? The next thing I like to do is, while I'm doing my probings, is I make a note of all the clinical attachment loss. I measure the depths of the pockets with my periodontal probe. I like to use the UNC 15 millimeter. I feel like that gives me a better reading and a better understanding of what's going on in the patient's mouth. I also like to evaluate the mucogingival defect. So I will mark all the patient recessions, all the recession the patient has throughout their mouth. And then furcations and mobility of the teeth. Finally, I like to end my examination by doing an occlusal analysis. So we'll make sure that there's no fremitus, crossbite, malocclusions, things of that nature. So right now I have a question from, and it states that why we rely on our dental hygienist in the diagnostic phase, and where does your handoff occur in the real world? So in my private practice, I always see any new patient that comes in through the door. So new patients walk in, I will do a comprehensive evaluation for that patient. When my become patients, active patients of the practice, then my hygienist will evaluate the patient depending on their maintenance on the maintenance protocol that I prescribe for the patient. So if the patient is going to be seeing us every 3 months for their maintenance appointments, at that 3-month appointment, my hygienist will do a thorough evaluation at each and every appointment. And then at some point during the 1-hour maintenance visit, and the maintenance visits are usually 1 hour at my practice, I will come into the office and I will reevaluate the patient with the guidance of my hygienist. So as I'm doing the examination, I always have an updated set of radiographs in front of me. And in periodontics, we always have a full mouth series of x-rays in front of us to help guide us throughout our examination, because we can't always see what's occurring underneath the gingiva, so the full set of x-rays acts as our map, if you will. And a full mouth series of x-rays with periapicals and bite wings are very important to us, because we can see the relationship of the tooth to the alveolar bone, and we can also determine the ratio of the tooth, the crown-root ratio, and this helps us in the prognostication phase of the examination. So moving along with the etiology, medical status is very important in periodontics. So we know that a lot of inflammatory diseases, and I'll get into what is an inflammatory disease in just a moment, inflammatory diseases play a very important role in the control of periodontal disease. And the control of periodontal disease plays a very important role in the control of the inflammatory disease. So some inflammatory diseases are diabetes mellitus, rheumatoid arthritis, atherosclerosis, any type of the autoimmune diseases. These are some very common inflammatory diseases that patients will present with to your office. So what I meant about the control is that if we have a patient who has, let's say, type 2 diabetes, if they are a brittle control diabetic or an uncontrolled diabetic, they have a very high risk factor to develop periodontal disease, or if they do have periodontal disease, they will have very poor control of the periodontal disease. But once they get their systemic health in control, then they are better able to control their oral health, and vice versa. If they're able to control their oral health, then the diabetes is more easily controlled. So these diseases play hand in hand with one another. Now, genetic factors do play a role in periodontal disease. There is a interleukin-1 beta, which causes a lot of destruction in patients' periodontium who have a family history. So if you have a family history of periodontal disease, you can be tested for that IL-1 beta gene, and that can help us determine how well controlled the disease can be, or if you are susceptible to the disease. So family history does play an important role, but medical status, inflammatory diseases, and those play a larger role in periodontal disease. So let's talk about treatment planning. Initially, what we need to do with our patients is determine why they're coming to our office. Are they in any pain? Is it an emergency appointment, or is it a new patient that's been sent to us by their referring doctor? If the patient is presenting with an emergency, we will do a very quick analysis of what's going on in that local area. And then we will treat that patient in that local area. We'll make them comfortable, but we will have them return to do a comprehensive examination. If the patient is simply seeing us due to a referral from a restorative dentist or another specialist, we will perform a comprehensive examination, gather all of our data, and then begin the treatment planning process. And the treatment planning process may begin with a non-surgical phase. The non-surgical phase is where we actually begin to treat any active disease, whether it be periapical pathology, active caries, or periodontal disease. And the non-surgical phase can be done either by your hygienist under your guidance, or can be done by the doctor themselves. In my office, it's usually the hygienist who will treat the patient in the non-surgical phase. Once the non-surgical phase is completed, we have to do an evaluation to see, can we move on to phase 2 therapy, which is active or surgical therapy. And in this slide, we have the maintenance phase before the surgical phase, but in the American Academy of Periodontology, the maintenance phase comes after the surgical phase. It's usually phase 3 or 4, depending on how much treatment the patient requires. So we'll perform the surgical care, and then we'll put the patient in a maintenance regimen, whether it's alternating with their restorative dentist or if this patient stays with us. During the surgical phase, if the surgical phase is an extensive one, the patient usually stays with us to perform all their hygiene appointments until they're stable enough to return to their restorative dentist. So in the periodontal treatment planning, there's a couple of objectives that we need to keep in mind. And the most important objective is to eliminate inflammation. So in order to eliminate inflammation, we need to determine what caused the inflammation, the etiology of the disease, and how we're going to remove it. So are we going to do scaling and root planing? Are we going to do regeneration therapy or extraction and preparation for implant placement? And when we come up with our different treatment options, we need to determine what is the prognosis for each option. What is going to be in the patient's best interest? What is the treatment that's going to give us the most predictable outcome and the most successful outcome? We also need to determine what the sequence is going to be. Is the patient going to need consultations with an endodontist, with an orthodontist, with an oral surgeon, or their primary care physician? Do we need to get an endocrinologist or another specialist involved in all of this? So we need to determine all of these things before we can actually initiate care for the patient. So the main point with all of dentistry has to be that we need to keep the final outcome in mind before we start. So we need to know, where do we want to end up? What do we want the patient to look like? What does the patient want to look like at the end of treatment before we begin the sequence of care for the patient? So again, the important part is going to be to eliminate the inflammation. And when we eliminate the inflammation, we will eliminate the bleeding, and hopefully we will either eliminate the periodontal pockets or we will reduce them and get the patient healthy enough to move on with the second phase of treatment, which is the surgical phase of treatment. And all of this is done to ensure patient health and to return them to health, but to prevent further bone loss from occurring, to prevent further teeth from being lost. So just a little bit more on the periodontal treatment planning phase. At this phase, we also want to correct any abnormal tooth mobility. So is there mobility because of occlusal trauma? Is there mobility because of loss of attachment? We need to identify what's going on so that we can better treatment plan and correct the mobility. And which goes on to the next point, which is the optimal occlusion. Do we need to reestablish or recreate that optimal occlusion? Or once the inflammation has subsided, will the patient return to optimal occlusion? In today's world of periodontics, we're very fortunate that we have a lot of predictable surgical techniques which will allow us to restore the patient's lost tissues, the lost periodontal tissues. And we also want to work closely with our restorative dentists to be able to have some very healthy, cleansable, and well-contoured restorations to not allow the periodontal disease to set in and to progress. And these are all very important. This is not stuff that you have to do by yourself. If you have a very well-trained hygienist that's working with you, or you can train your hygienist, this can all be done by the hygienist, and all you need to do as the doctor is come in and confirm the findings of the hygienist, or help the hygienist make these diagnoses or notations of what's occurring. So my hygienist has been in the world of periodontics for 15 years. She and I have been working together for many years, so she knows the sequence of treatment that I like to go through. And so when she does her examination, she follows my sequence to make sure that we haven't lost anything or forgotten to evaluate anything. So we're able to work together to come up with a plan for the patient. So the non-surgical therapy, as I mentioned earlier, in my office is mainly performed by my dental hygienist. So initially, before beginning this non-surgical therapy, my hygienist will gather all the data. She'll look over the patient's medical history, see if we need to receive any consultation documentation from the clinician. And if we haven't received it, she'll get in touch with the physician to gather that documentation so when the patient comes in, she's ready to begin the treatment. Initially, what my hygienist will do is begin with a plaque score regimen. So she'll give the patient some disclosing solution, and then she'll, with the patient's help, they'll determine what the patient's plaque score is. And that'll help the hygienist and the patient to determine which areas the patient's not doing so well with their home care. So as the appointment goes along, my hygienist can teach the patient better ways, more effective ways and more effective tools to use to maintain optimal home care. So throughout the procedure, she's not only working or treating the patient, but she's educating the patient on proper home care, the links between systemic health and oral health. She's discussing the different types of dental instruments that are available, different types of flosses, interproximal brushes, electric toothbrush versus manual toothbrush, different types of toothpaste. And she'll really try to come up with a plan that suits the patient's needs. And while she's doing this, she's going through the actual physical process of scaling and root planing, removing the plaque in the calculus, supra, and subgingival, attempting to decrease the bleeding on probing and the inflammation throughout the mouth. So the oral hygiene education part of the treatment is just as important as the physical debridement. So what the non-surgical therapy does, I'm going to go back one slide. What the non-surgical therapy really does is allow us to decrease the inflammation, but most importantly, it allows us to see the patient's compliance. How dedicated is the patient to making a change? Can the patient implement the techniques that the hygienist has taught the patient? Because if the patient cannot follow directions or is non-compliant, the surgery that I recommend is going to be unpredictable and it's going to be unsuccessful. So you're going to have an unhappy patient and you're not going to be able to achieve the goals that you have set out for the patient. So it's not uncommon for a patient to go through the non-surgical phase many times until they can prove that they are able to comply and move forward onto the surgical phase of therapy. So the next slide talks about antimicrobial mouth rinses and the role that they play in the non-surgical phase. I am not a fan of antimicrobial rinses. I think it gives the patient a false sense of cleanliness, if you will. I prefer the patient to use an electric toothbrush, brushing 2 times a day for 2 minutes, and then to floss at least once a day. And if needed, and interproximal brushes and tufted brushes, rubber tips, whatever else the hygienist and I have recommended for them to use to enable the patient to keep their mouth clean. If they feel like their mouth isn't, if they've got bad breath, if they have halitosis, or just don't feel clean, then at that point I would recommend them using a mouthwash. The only time I will prescribe an antimicrobial mouthwash is after surgical treatment because I do not want the patient to be brushing around an area where I have performed surgery, where there's an open wound and there's sutures in the area. So very rarely do I use an antimicrobial mouth rinse during the non-surgical phase. Now there are some patients who will require it, but for the most part I do not prescribe antimicrobial rinses. So again, going back to the non-surgical phase, the non-surgical phase is mainly done by my hygienist, and this is where we do the periodontal scaling and root planing and the oral hygiene instruction. My hygienist will either perform the scaling and root planing in 2 appointments or 3 or 4, depending on what the patient's needs are. Some patients will ask to be anesthetized throughout the process. Other patients don't require to be anesthetized. It's really whatever's in the best interest of the patient and what makes the patient more comfortable. This is a great time as well to have the patient seek consultations, whether it's with an endodontist, an orthodontist, a restorative dentist, so that we can correct any of the non-periodontal issues that may be contributing to periodontal disease. This is a great time for caries control. This is a great time to remove any active disease. One point that I did want to make, I am not I do not believe in splinting teeth. The Academy at this point is not in favor of splinting teeth. We feel that splinting teeth creates a plaque trap, and patients are not able to successfully or effectively clean around a splint. Now there's a difference between splinting teeth and using a fixed retainer in orthodontics. Orthodontists are now moving towards the belief that patients should have fixed retainers post-orthodontic therapy to prevent relapse of rotation or the movement of the teeth. So patients who have fixed retainers, there are wonderful instruments that they could use to keep the area clean, but we don't feel that splinting periodontal teeth together is a good idea at this time. So one thing that's important after we perform the physical non-surgical phase of therapy is to bring the patient back for a reevaluation. And again, this part is performed by my dental hygienist. So the literature states that 4 to 6 weeks after performing scaling and root planing treatment, the patient comes back for a reevaluation. And essentially what that reevaluation is complete regathering of all the information that we gathered at the initial patient visit. So the information that we had at the initial patient visit is the baseline data. The information we gather at the 4 to 6 week is what we call the most current or the new periodontal information and the periodontal condition of that patient. So again, we're looking for pocketing, we're looking for the clinical attachment loss, we're looking for bleeding on probing and if there's any inflammation present. But again, most importantly, we're looking at the oral hygiene of the patient. Was the patient able to maintain and perform the oral hygiene, the home care that we had prescribed for them? So the reason why we do the care reevaluation at 4 to 6 weeks is that during the 4 to 6 week period, the inflammation is subsiding and we're able to get some reattachment of the fibers post-treatment once the calculus subgingivally has been removed. So this is the best time that we can get the most accurate readings for the patient. And again, this is if and only if the patient has been able to perform good plaque control and decrease the inflammation. So we have another question which states, how much does the literature influence your patient recall intervals versus what you and your dental hygienist see firsthand? I am a very big believer of evidence-based dentistry. Periodontics is a very deeply rooted specialty in research. A good periodontist, a board-certified periodontist, bases almost all of their clinical decisions, what materials to use, what techniques to use, what interval for hygiene, on the literature. And so I would say almost all of my decisions are made based on what the literature will state. Now, I do have those patients that I know when I send them off will not brush their teeth, and I will have them come in more regularly. I do have young patients who are in full orthodontics that I know are going to be non-compliant. So I will bring them in on a more regular basis rather than what the literature will state. So there are exceptions to the rule, but I would say 95% of the time my decisions are made based on the literature. And the literature does state that in a susceptible patient, in a patient with risk factors for periodontal disease, the gram-negative bacteria will reemerge and begin to cause inflammation at about the 90-day point, which is 3 months. So my high-risk periodontal patients are on a 3-month maintenance cycle which is either every 3 months at my office or alternating with their restorative dentist. So they will see me every other 3 months. So 2 times a year the patient will see me, and 2 times a year the patient will see the restorative dentist. Okay, so going on to a statement from the Hygiene Association. So it's very important that we work together with the dental hygienist so that we can make sure that we've identified the disease, but we've also educated the patient on what is going on, what the disease is, and to be able to address the disease. So what is the role of a dental hygienist? Just to take a little side comment, is that when you're a dentist in a practice, you can't be everywhere at once and treat every patient all the time. You need to rely on your team. And you can rely on your dental hygienist because he or she has gone through the proper schooling, the 2 or 4 years of training that they require, and they are board certified. They have gone through examinations, rigorous examinations, much like the dentist has. So they have an understanding of the science, and they have an understanding of the clinical. So they can be your partner. Now, they may not be able to diagnose, but they can be a partner and help you treat the patient. So my hygienist plays a very, very important role in my practice. She has 1 hour to treat the patient, and so she spends an hour discussing what's going on in the patient's life, in the patient's home care, in the patient's oral cavity, and she's actually performing the treatment on the patient. I can only come in for 5 to 10 minutes and quickly evaluate the patient. So she spends more time than I do with the patient and is able to access more information from the patient, and so we can better work together to come up with a plan for the patient. So it's all about the teamwork. The hygienist cannot diagnose, but can give you clues and aid you or lead you to the diagnosis of the treatment. So we have a question, and it said, how did you find her, and how did you build the rapport when we met? So I was very fortunate. My hygienist, I purchased a practice, and my hygienist was working in the practice prior. She was a dental assistant in the practice and then went on to hygiene school and then returned back to the practice as a dental hygienist. My hygienist loves science. She loves research. And so she performed a lot of research when she was a hygienist, when she was in hygiene school. And so she has gone back, and she's actually faculty at the local hygiene school. So one thing I appreciate about her is that she is constantly learning. She's attending hygiene meetings. She's attending perio meetings, restorative meetings, so that she can stay on top of the research as much as I do, so that we can be pairs in treating the patient, properly treating a patient. So it's very important to not only educate yourself or continue to educate yourself, but to educate your hygienist. Because once you show them that you care, once you show them that you want them to be your partner and enable them by going to these study clubs or these continuing education courses, it'll build their confidence, it'll build their education level to make you a better clinician, a better diagnostician. So that's how we built our rapport together. I gave her the opportunities, and she took me up on the opportunities, and we're able to work very well together. So I hope that answers your question. It's a long process, but it's very worth your while. So the role of my dental hygienist is, besides doing the physical care, she will also educate the patient on home care, but most importantly, she talks about the ties between systemic health and oral health. She'll talk about the different types of oral diseases and why it's important to perform the home care at home, why it's important to come in for these regular maintenance visits. Now, x-rays are one thing you may not know about x-rays, but x-rays are considered to be a treatment. So unless the doctor gives a diagnosis, recommends the treatment, the hygienist or the assistant cannot take a radiograph. So in my office, I will diagnose the need for a radiograph, and my hygienist can then come in and take the radiograph. And she can make a suggestion to me. She could say, Dr. K, I see a radiolucency around this root tip, or Dr. K, I see some bone loss on this radiograph, or calculus. She can give me suggestions, but she cannot make a diagnosis, nor can she take the radiograph without consulting me. So it's very important to have that trust with your hygienist, but let them know that you are in the driver's seat. And it also goes back to taking good radiographs. You can't take a radiograph just to take a radiograph. The radiograph must be diagnostic. The other nice thing about educating your dental hygienist is you can't always be there to discuss the patient with clinicians such as the endodontist, the restorative dentist, or the medical professional. So if you have an educated dental hygienist that you're working with, the dental hygienist can field those calls or help answer any questions if you, as the doctor, can't get to the phone to help the practitioner. So again, moving right along, the role of the dental hygienist is, again, to help with the treatment planning, to help implement the care, to educate the patient, and to go through it. And again, the role of the dentist is, first and foremost, to do no harm. Our goal is only to help patients. And we can do that by working as a team with our hygienist and our other healthcare professionals. If at any time you don't feel comfortable with making a diagnosis or comfortable treating a patient, do not hesitate to let the patient know and seek a second opinion yourself, or send the patient for a second opinion. You do not have to treat every patient that comes in the door. So I am a huge believer in teamwork, whether it's teamwork within my team or teamwork within the whole dental scope, the whole dental family, if you will, that the patient belongs to, the restorative dentist, the orthodontist, the oral surgeon. And I am in constant contact with them. When I say I, it's not just I, it's myself, my hygienist, my office manager, my implant coordinator, whomever it is. It's important for the team to work with the team of the other healthcare providers so that we can properly communicate, but also accomplish the goals that we have set out for the patient. And it's nice to have a collaborative effort, because there are sometimes things that I miss and another practitioner can bring to my attention, and so that will lead us to better treatment, more effective treatment for the patient. So going back to our earlier question about how to build rapport, the environment that I've created in my office is one of education. We are constantly learning and we're constantly reading. And by doing that, not only are we educating ourselves, but we're becoming better clinicians so that we can treat our patients better, more effectively, more efficiently, and that they are more comfortable with the care that they receive. And hopefully we may not be able to cure periodontal disease, but at least we can keep the disease at bay. And the patients are treated in a safe manner. I love this slide, and I think it's very important to understand the difference between an interdisciplinary approach and a multidisciplinary approach. Multidisciplinary is a slight difference in the terminology, but the multidisciplinary approach is the restorative dentist working by themselves, the orthodontist working by themselves, the periodontist working by themselves, and no one is communicating with one another to help the patient through the process. But in the interdisciplinary approach, that's where the orthodontist calls the restorative dentist, who calls the periodontist, and they have a conference together to meet with the patient, to have a team approach on how to care for the patient. Now, someone has to be the quarterback, but it helps when we're all sitting at the table together so that we can achieve that one goal into caring for that patient. And I have to say, your patient actually appreciates what you're doing, and they're more apt to move forward with the treatment, with the care. So again, going back to fostering a team approach, open-ended questions are very important in the dental field. You don't want to go into the patient and ask them questions where they'll answer with one-word answers. Are you in any pain today? Yes, no. That's not going to get us anywhere. What type of pain are you having? Where is the pain? You want to ask them more general questions, and you want to listen to the patient. And again, your hygienist spends a lot of time with the patient, and when they talk about social issues, some of the answers to some of the questions that they're having or some of the concerns that they're having can be answered by just listening to your patient, and your hygienist can help you with that. They can tell you that the patient's been under a lot of stress. The patient's been traveling a lot and hasn't been able to perform their home care. There's a lot of answers that can come from a simple conversation your hygienist can have with the patient. And we can find out from the patient, well, we're going to have a stressful quarter coming up. Work is going to be really stressful. So we may know that might be their breakdown time of the periodontium. We may need to see them more often during that stressful quarter. Or they might be having exams coming up, and we know that's causing stress, or whatever other thing might be coming up in their life. We can help tailor the treatment to meet the needs of their life. I'm sorry, I think I may have skipped a slide. So if we have time, we'll go over a case study. And this is not one of my cases, but it's a great way to illustrate how we can walk through the treatment of a patient. So a 30-year-old non-smoking female comes in, and we evaluate what type of biotype the patient has. We'll go over an examination with the patient. And in my office, I like to do the initial visit, but there's no rule or law that says that your dental hygienist can't do the initial examination for you. It's whatever works best for you and your office. So either person can go in, meet the patient, perform an examination, and most importantly, find out what brings the patient in to the office that day. So the second phase comes to the patient reports that they've had endodontic therapy, and they've had significant amount of treatment, and a radiograph was treatment plan to be taken and was taken. And at this point, the hygienist can take that radiograph for you. The hygienist can do some of the initial initial identification of the issues at hand before the doctor even comes into the door. And then in the treatment planning phase, the hygienist can play an important role because you can seek their input. How is the patient's home care? Do you think the patient is compliant? Was the patient open? Was the patient open to any suggestions that you had made? What is the patient's mind frame? How much treatment can they do? And it's a great approach to this topic because they can ask simple things like, have you ever thought about orthodontic treatment? Would that be something you're interested in? Or have you ever thought about implants? Do you know anything about implants? This is a very nice way to begin the conversation with the patient. So when the doctor comes in to speak more firmly about a treatment option or a treatment plan, you have an idea, a sense of where the patient is coming from. And then in this case, the patient decided to go forward with implant therapy. And for me, it's very important for the patient to maintain good home care, whether it's around implants or natural teeth. And this is where the hygienist comes into play with the physical maintenance part of it, and also the home care instruction, what type of brushes, what type of floss, what type of instrumentation that they need to use in order to keep the area clean. And again, this is a radiograph of the final product. And again, just going back to the hygienist can help with educating the patient and keeping the patient abreast on the newest findings with systemic health issues, with oral health issues, and with their home care. And this is how the patient finally, the final care of the patient turned out. So just to summarize, a position paper that the Hygiene Society had put together is that it's so important for dental hygienists and dentists to work together. If you don't use your dental hygienist, you are losing out on a wonderful resource in your practice. you can be a great team with your hygienist to perform great care for the patient, to educate the patient, and have a wonderful outcome for any of their dental needs. And that is about it. So if there's any questions, I'm happy to take them right now. If there's any comments or you'd like me to elaborate on anything, I'm happy to take those right now. So I have a question that says, do you socialize with your hygienist out of work? I mean, other than the learning venues, how do you separate your roles? I do team building events. We'll do about 4 events a year, but outside of going to team building events or learning, going away to CEs or anything like that, I do not socialize with any of my staff members. We have a very we try to separate our personal lives from our work lives, which seems to work very well for my practice at least. Any other questions? Any other concerns or any other questions about diagnosis or treatment planning or radiographs? So if there are no further questions, please take a couple of moments to take the survey. I hope this was helpful, and it was a pleasure being able to present this topic that's very important to me. I hope you have a wonderful evening, and again, please don't forget to take the survey. Have a wonderful evening, and I hope to perform another lecture with you soon. Have a wonderful evening.